Good evening to all. Today is the 1st August, and we had scheduled our webinar of awake surgery for glioma. So today we have another expert on, definitely an expert and pioneer in awake glioma surgery, Professor Takashi Maruyama. He's from the Tokyo Women's Hospital. Professor Maruyama is a pioneer that he's the one who started awake craniotomy for glioma in Vietnam and many other hospitals, universities across Vietnam. And we are so fortunate to have you here, Professor. You may please share your screen and start the presentation, Professor.
Hello, everybody. I'm from Japan. It is around 9:40 night, and I'm glad to join this opportunity. And also, let's see. Okay. Glioma surgery in the eloquent locations, we need a balance between removal rate and also complication rate. Usually, we have to think about awake surgery because of the prediction of the diagnosis and also, of course, tumor location. But we have to think about patient survival and also quality of life. So that means we need to make a plan with not only location, but also age, occupation, familial support, and also patient personality. Awake surgery. Here is a paper of New England Journal. This is 2000. It says that opening up brain surgery, if it means awake surgery. And also in 2008, Mitchell Berger mentioned about the functional outcome after language mapping of glioma resections. So maybe all of you know about what's the meaning of awake surgery. Here is our OR. This is 0.4 Tesla intraoperative MRI, and also we are doing awake surgery in the IEMAS space, like this. And here is cases since 2000. Our department started first awake surgery in 2000, and usually we do awake surgery maybe around 40 to 50. Now number is increasing. And let's say this is a patient of 24 years old unmarried woman. Well, this patient, she's a college student. I don't know. Well, it was right side, so it's non-dominant. However, she want to be a TV anchor. She was a college student, and she did not want to lose her speak ability. So I did awake surgery, not only for confounding language, but also speech. And yeah, we got removed almost total. And post-operatively, she didn't have any deficit. She did have a slight dysphagia, however, fully recovered within 3 months. So not only the eloquent, such as language area, but also non-dominant hemisphere, sometimes we use awake surgery. This is the research work we did, which is already published in Brain Language 2009. And we tried to find a functional MRI on the right hemisphere language area. And we found that some kind of connection between right and left opercular region was proved. So, and also here is a classical broca's mapping. Maybe all you know. However, now we have a human connectome project. And this is a paper published in 2016 by Nature. And they found that not only classical brain mapping, but also human connective network found that additional 180 areas per hemisphere. So the broca map is now rewriting like this. Here is the left side, and this is the right side. Still, the brain perception is more accurate and more details. So here's our awake surgery protocol. We use propofol, and also we use laryngeal mask. And after the induction and craniotomy, we stopped all the propofol, and we do make patient awake. And during this awake phase, we do cortical mapping and also continuous monitoring. Then we will close. During the closure, we will add another propofol. Okay. Well, I will show you the brief video of awake surgery. After opening the scalp, opening the brain surface, then we scanned first MRI. And after the scanning, we make patient awake, extubated, and also we start brain mapping. Well, sometimes this kind of tools is very useful. Also, the update MRI image are integrated into the navigation. So I use post-opening MRI guided navigation. This is a large insular tumor. And here is the image. 0.4 Tesla MRI is, well, sufficient. It is enough for the MRI during the surgery. And this is the monitor. We watch patient face, and here is tasks, and surgical microsurgical field, and here is the patient condition, and also navigation. This all data integrate into the one monitors. So this is very useful for the awake surgery. And also, to success good awake surgery, we have to use local anesthesia. This local anesthesia is very important. And also, this is an injection site. We have to block all the nerve of skin. So with good local anesthesia, patient does not feel uncomfortableness. And here is a laryngeal tube. We do not. We usually fix patient head, and we do not remove this. And we have to make patient position like flat, does not rotate that much. And also, we usually do cortical MEP, muscle evoked potential. So this is all the needle, and also calibration is in here, and also hand. Skin incision is another issues. Usually, of course, we use large question shape scalp incision. However, if I use this skin incision, then this flap cover the right eyes. So we prefer to do a T-shape scalp incision like this. With this scalp shape, this skin flap does not cover the patient eye, so patient can see the monitor with both eyes. This is a patient with left side large tumor. you can see the tumor here. Tumor removals usually we do under continuous conversations. And this patient, here is the eloquent locations. So this only small cranial window, small cortical window, we cannot damage this surrounding eloquent area. However, continuous conversation keeps patient speech ability, does not make any damage. So here is a post-op, and the patient was grade 3, and patient survived more than 10 years. And also, there are different types of speech. This patient showing the negative motor area damage. Usually, there is a positive motor, and also there is a negative motor area. And this negative motor area speech function is very rare. So you can see the scattering speech of the patient. This is orofacial motor. It was not smooth. So this patient, the tumor was located on the negative motor area. So we can stimulate the broca area and also orofacial motor area. However, direct stimulation of negative motor area makes patient speech scattering. So this is very rare case. Here is the fibers, main 4 fibers related to the speech language association. And also you need to see the anatomy, such as SLF. There are 4 different routes of SLF. However, the main route of SLF and also IFOF, inferior front occipital fasciculus, is another important fibers. Also, if you success the awake surgery, you need to know the anatomies. I usually educate younger doctors, such as the atlas. Here is the Sylvian fissure and anterior Sylvian point, which the meeting point of anterior ascending lambs and also horizontal lambs. This anterior Sylvian point is 1 centimeter next to the terional. And this anterior Sylvian point is the center of broca area. And after deciding anterior Sylvian point, then 2 centimeter posteriorly, there is an inferior orangic point. This is central sulcus and also Sylvian fissure meeting point. So you can find out the anatomy, such as precentral gyrus and also frontal operculum. Also important anatomy is inferior frontal sulcus and precentral sulcus meeting point. This point is also very important. Next patient, the tumor is located in the frontal operculum, such as inferior frontal gyrus. Let's see. The speech was stopped. This means the broca area is elevated up to the middle frontal gyrus. So inferior frontal gyrus, Usually there must be a functional area. However, the most important language area is in the middle frontal gyrus. So we did remove inferior frontal gyrus, such as frontal operculum. The patient keep awake, and I removed the tumor with continuous conversations. And here is a post-op. You can see that the frontal operculum was totally removed. However, this patient, she didn't lose her speech ability. Patient was anaplastic oligoastrocytoma, but the 1p19q is all lost. So this patient is still surviving. She's 6 years past, but there's no recurrence. If we can predict the patient longer survival, we need to avoid complications. Oligodendroglioma, oligoastrocytoma, usually have IDH mutant type, and also they have 1p19q LOH. So the WHO 1016, it was categorized as oligodendroglioma IDH mutant type. And from our tumor bank data, we counted grade 2-3 gliomas, 250 patients. And if we can see the calculation into the tumor, that means more than 90% patient was had a 1p19q LOH. So in case if you see the preoperative scan with calcification, that means this is a longer survival tumor, such as oligodendroglioma. So you don't have to remove completely. You can take out the tumor without any complications. This is a patient with large calcifications. She had intratemporal gliomas. Patients with GCS onset. So we did remove only T1 low area. We did not remove T2 high or flare high area. Here is a post-op. And you can see that there is a remaining flare high area surrounding. However, this patient was diagnosed as GBM with oligodendroglial components such as GBMO, which old classical analysis. However, the patient is still surviving without recurrence. However, instead of GBM. So this kind of tumor is large because the slowly progressed, slowly growing tumor. Then patient does not show any neurological deficit. In such a case, you don't have to remove completely. You don't have to remove as much as possible. No, just take a part of the tumor. Next question. We have a clinical question such as, does safe resection guarantee longer survival in oligo patient? As I mentioned that we have analyzed our tumor bank data and we categorized WHO 2007 into WHO 2016. However, there are unclassified oligodendroglioma. I told you that the oligodendroglioma, if there is a calcification, you don't have to remove completely. However, the analysis here, this showing that the grade 2 and grade 3 oligodendroglioma, it seems like quite good survival. However, in 10 years, there are several patients, such as 20% patient was died instead of oligodendroglioma component. So we check all the early deaths in oligo patient. We had 208 oligo patient, but patient died between 10 years. 23 patients died. And this is all the data. It seems like there are some patients who have IDH mutant, 1p19q co-deletion. However, the patient had a short survival. There are some other missing factor X. Maybe this must be CDK4A or some another molecular marker is now coming. Maybe this will be influenced to the next WHO classification. However, until oligodendral glioma, still we have to remove as much as possible. This is a patient, a 29 years male patient, seizure onset without no deficit. We did awake surgery in 2008, and diagnosis was anaplastic oligodendral glioma. And here is a post-op. First-round treatment, we did 60 gray radiation with PAV therapy. And I removed, let's say, more than 90% removal. And this is the next year. However, 2 years later, this is 2009 December. This is 2010 February. Another 2 months, we found the aggressive tumor recurrence. It was diagnosed as oligodendral glioma with LOH. So this is a patient which have something missing factor X. So still, oligodendral glioma, we have to remove as much as possible, and we have to follow chemo and radiation therapy. So that means we still need safe but maximum removal for oligodendral glioma patient. Sometimes we need to do a multi-step strategy. This patient, she was another epilepsy onset patient, left frontal SMA region, and preoperative TMS showing that the posterior edge, there must be a motor eloquent area. We did awake surgery for her, and during the awake surgery, patient awake condition was not sufficient. And in this part, she showed mild motor deficit. It was SMA syndrome, but still during the surgery, we couldn't confirm her right hand motor ability, left foot, right foot motor ability. So we stopped surgery and we did first radiation and ACNU, and we did just observations. After continuous observation, tumor was regrowth. And in another 2 years later, patient showed epilepsy and it was hard to control. So we did another second awake surgery. Second surgery has been performed in awake condition. And after the second awake surgery, we did almost complete, totally removed. Patient had no deficit, and tumor was embedded into precentral gyrus, half of the precentral gyrus, but posterior half of the central gyrus was intact. So we did remain in this area with awake conditions. Also, sometimes we have to discuss about plasticity. This patient, he had left frontal operculum low-grade glioma. Functional MRI showing that the functional speech function area is in the anterior half of the tumor. So here is the surface, here is the inferior frontal sulcus, here is the Sylvian fissure, and this is the central sulcus. So this blue point was negative motor area. This is after first surgery. We did remove the pars frontalis and orbitalis, pars triangularis and orbitalis. However, we couldn't remove pars opercularis because there was a functional response, such as here is a broca area, here is a negative motor area, and also this is a anterior surface of this gyrus. We found negative motor area, broca area, and broca area. So this patient, we did stop surgery Here is a preoperative MRI, and this is a postoperative MRI. You can see that the pars opercularis is still remaining. Tumor was diagnosed as oligoastrocytoma 1p92 LOH. So we just observed this patient. However, the tumor was recurred. So tumor was regrowth. So we did scheduled second surgery. And here is a view of second surgery. Well, this gyrus, we found the broca area on this gyrus. However, second surgery, we couldn't find any functional area here. The eloquent area was displaced to the posteriorly, and the precentral gyrus, the broca area, we found the broca area reaction. And so this second surgery, we could remove pars opercularis. Here is a post-op image. You can see that this gyrus was completely removed. So this is a kind of plasticity. So in case if you found some eloquent functions, then you don't have to remove as much as possible at that surgery. You can remain the tumor and watch over. Then if you diagnosed was grade 3, then you can do chemo and radiation therapy and just watch. And after the growing, you can do another second awake surgery. So awake surgery, we need to do, this is important that maximum safe removal with awake surgery. We can evaluate functional area in or out with mapping. Also, we can avoid permanent deficit by functional monitoring. We have to decide go or no go based on the diagnosis and functional evaluations. Well, here is a picture of my first awake surgery in Vietnam. It was 2019, and this is Professor He in Hanoi University Hospital. Well, every 3 months I visited Vietnam hospital, and we introduced awake surgery technique. And this is the picture of first awake surgery. And here's a patient. The patient, this is 1 year after the patient. This is insular tumor was removed, and the patient is fine. And let's see. I'm glad to help Vietnamese Neurosurgical Society. And also, you can find out the guidelines of awake craniotomy. There is only guideline in Japan. So in this guideline, you can find a technique and also the tasks. And also this must be the one that you can follow the technique. Okay, this is it. Sorry about my English. I didn't prepare, so my English is not that good enough. But however, I hope that this will be helpful for all of your neurosurgeons.
I really sincerely thank you from the bottom of my heart on behalf of the ACNS Education Committee and Professor Yoko Kato. I will take a few questions. There's a question from XMAX to everybody. Do you believe that staying inside tumor will lead to no deficits if not doing awake?
Okay, answer is almost yes. However, I saw 2 patients. One is SMA region, one is left frontal operculum. At that patient, the patient was diagnosed as grade 2, and it was diffusely flare high. So it seems like tumor. And we confirmed that there is a minimum amount of tumor cells. So in some case, flare high image sometimes have both tumor, but also neuronal functions. Very rare, however, still there are some patients. So especially if you have strong high region such as T2 or flare, then Maybe it's definitely there's no function within the tumor. However, diffuse high area, you have to be very, very careful. I think that I recommend doctors to do mapping.
Right. Thank you very much, Professor.